Hi, welcome back to IU Radiology Case of the Day. My name is Nick Kuntz, and I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I'm back with another interesting head and neck radiology case of the day. As always, I'd like to start by stating that all of the educational content found as part of this presentation has been completely de-identified in order to protect patient privacy. So the history of this patient, they were an early 40-year-old man that had a neck mass. So I've got 4 images for you to take a look at. The top left is a transverse grayscale ultrasound. The top right is a transverse color Doppler ultrasound of the same location. Bottom left is an axial contrast enhanced CT. And the bottom right is a coronal contrast enhanced CT. So keep in mind the history. The patient was in their early 40s and they had a neck mass. Take a look at these images, try to figure out what you think is going on here. Okay, so I've got 3 questions for you this time. First of all, what are the findings? Second, what's the most likely diagnosis here? And the third question is, what's the next appropriate step in the workup of this patient? Something that you as a radiologist can do. Okay, so let's take a look at the imaging. First up, we'll look at the ultrasound. And what you can see is a largely circumscribed ovoid anechoic mass. It does have areas of posterior acoustic enhancement, but it's not entirely anechoic. And importantly, you can see that we have a heterogeneously hypoechoic nodule at its deep margin, denoted here by the yellow arrow. Now overall, this mass tends to be taller than wide, and that's something that we worry about with masses, whether it's in the breast, whether it's in the neck, because that can suggest that there's some deep invasion through the tissue planes. And if you look very carefully, you can see that there are punctate hyperechoic foci, some of which show true posterior acoustic shadowing. So that makes us concerned that maybe there's calcification within this mass. Anytime we see a mass in the neck or a mass anywhere on ultrasound, throw on the color Doppler, look for vascularity, look for flow within it. And what you can see in this case is we do have some internal vascularity within that hyperechoic nodule. And that's consistent with a vascular mass that's associated with this cystic lesion. So let's take a look at our contrast enhanced CT. Again, this is an axial contrast enhanced CT through the level of the cystic mass that you can see denoted here with the yellow arrow. Now we're in the infrahyoid neck, and if you'll notice, this mass sits just right of midline. And it's closely associated with the right-sided strap musculature, which, as you can see by this arrow, has been displaced, sort of pushed a bit laterally. And we can also see a frond-like area of enhancing soft tissue, that nodule that was at the deep margin that we saw in ultrasound. And if you look carefully at this, you can see that it does in fact have little stippled foci of calcification. And that's a really important finding in this case. Take one more look at this time in the coronal plane on the contrast enhanced CT. And again, we see the cystic mass sitting more or less to the right of midline and to the right of midline. And you can see it's closely associated with the right strap musculature, which has been displaced, denoted here by this yellow arrow. And again, we see that frond-like enhancing soft tissue nodule that sits at the deep margin of it. And if you look carefully, again, we see areas of stippled calcification. So, what's the diagnosis in this case? And what's your next step in terms of something that you as a radiologist can do to try to add some more specificity to this diagnosis? So this is a patient with thyroglossal duct cyst carcinoma, and this is a malignant tumor that arises from a thyroglossal duct cyst. Now, thyroglossal duct cysts are the most common congenital neck lesions, and they can be found anywhere from the base of tongue all the way down to the thyroid bed. In the suprahyoid neck and at the hyoid level, they tend to be midline masses, but once you get into the infrahyoid neck, they sort of fan to the left or to the right, heading toward the thyroid lobes, part of that normal descent of the thyroid down the thyroglossal duct. Most of the time, in fact, the vast majority of the time, when you have thyroglossal duct cyst carcinoma, it'll be papillary thyroid carcinoma. Very rarely, probably less than 5% of the time, do we have squamous cell carcinoma that arises here. Those tend to be more aggressive. Fortunately, this is an uncommon diagnosis. It's been estimated that somewhere less than 2% of thyroglossal duct cysts actually harbor thyroglossal duct cyst carcinoma. Something that's important to look for whenever you see a patient that you suspect of having a thyroglossal duct cyst is to look for a solid component, especially if that solid component is associated with calcification. Now, if you see a soft tissue component, it's a bit nonspecific. Certainly you need to be thinking about malignancy, but you can also get that soft tissue component as a result of prior infection or inflammation, and it truly has lower specificity for making the diagnosis of thyroglossal duct cyst carcinoma than if you were to see the calcification. If you see calcification, that's always concerning, and that has a higher specificity for it being malignant. So again, just to rehash to make sure everyone is on the same page, look for soft tissue. If you see soft tissue component with it, you certainly need to have some suspicion. Just know that the specificity is lower than if you see calcification. If you see calcification, that is always concerning for the thyroglossal duct cyst harboring a thyroglossal duct cyst carcinoma. So this is a great paper that I think if you're a neuroradiologist, if you're a head and neck imager, if you're a neuroradiology fellow, you should be familiar with. This was written by Christine Glastonbury and colleagues. And this was looking at the CT and MRI appearance of carcinomas that arise in thyroglossal duct remnants. And this certainly was an important paper in helping to delineate the importance of looking for that soft tissue, but especially looking for that calcified component, which ups the suspicion that we're dealing with thyroglossal duct cyst carcinoma. So definitely take a look at this paper published in AJNR back in 2000. Okay, so let's wrap this up. This was a patient who had thyroglossal duct cyst carcinoma. And the imaging features that you need to know about for this case is, first of all, we had a cystic mass that was midline to just midline, just right of midline. And again, with thyroglossal duct cysts, if they're in the suprahyoid neck, they tend to be at midline. If they're in the infrahyoid neck, they oftentimes sit paramedian. So that really replicates the course of a thyroglossal duct. So again, in this case, we had a mass that was at and just right of midline in the infrahyoid neck that was cystic. If we looked carefully, we saw that frond-like nodular soft tissue component that was, of course, suspicious, but we also saw calcifications, which are incredibly suspicious in this setting for thyroglossal duct cyst carcinoma. So a couple pitfalls to keep in mind. The soft tissue component is important. You absolutely need to look for it. Just keep in mind it's nonspecific. It may be due to inflammation, or it may be related to underlying malignancy. When you see calcification, that is always suspicious. That's a very highly predictive feature for deciphering whether or not the patient has thyroglossal duct cyst carcinoma. So what can you do as a radiologist, sort of wrapping this all up? These patients need an FNA, and that's something you can do under ultrasound guidance. When you do that, you need to target the solid component. Don't just aspirate the cyst contents and send for cytology, because it may undersample and you may get a false negative result. So if it has a solid component, you need to target it, and if it is strictly a cystic component, certainly send that for cytology, but try to get some soft tissue component while you're at it, because that will increase your diagnostic yield. As always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and I would invite you to check out our complete collection of IU Radiology Case of the Day materials that can be found at radtf.iuhealth.org/COTD. Thanks so much.